Good evening, everyone. Hope I am audible and clear.
Yes.
Thank you, ma'am. Thank you for confirming. So, welcome back to the third session of our foundation course in palliative medicine. Today, as a part of the modules on pain management, we'll be discussing the management of pain part 1 with focus on NSAIDs. And we have one of the most eminent and experienced faculties in the country, Dr. Mary Abraham, joining us in the evening to walk us through the session. So, without much delay, for the faculty introduction and further session facilitation, I hand over it to Dr. Rata Venkatesh. Ma'am, it is over to you.
Good evening. We are slowly getting into the crux of palliative care. Okay, what you all need to know. And so many queries were there in all of you during your previous session when we had the introduction to it. What happens? What do we do? Slowly, in the next coming 2 to 3 sessions, most of them, I could say all, but I'll put it as most of them, will be solved with the eminent faculty taking you through the important topic. A warm welcome to you, Dr. Mary Abraham, who is a neuroanesthesiologist and a pain and palliative care physician. She is a visiting consultant in many hospitals in New Delhi, and she has been awarded the Lifetime Achievement Award for her work and contribution to neurosciences in Delhi in 2017. And her main interests are neuroanesthesia and palliative care. And she's also authored a book, Important, Conquering Pain, in 2019. With that, I hand over it to you, madam, to take us through the session today.
Good afternoon, good evening. Thank you, Radha. Once again, we are together again. Huh?
Nice.
Radha, I hope you're not bored with my talk each time.
No. We both, see, it's the same thing. And in fact, in our previous session, they were all asking about pain. I said, don't worry, you've got few sessions. What, when, about everything. I said, I won't spoil the richness, or I won't take the taste away. Leave it there. You will all have in the next few sessions. So that's what they're all going to enjoy, madam. So it's a pleasure to be with Palim and with you.
Yes, and Shri Priya, thank you once again and for hosting the session. And without much ado, I'd like to just say that it's always a pleasure for me to take these classes. Although now I'm also working as an anesthesiologist in the daytime. I've joined Hamdard University also. So now in the day I'm an anesthetist, and in the afternoon I'm a pain physician. So I wear 2 caps now, but I still enjoy taking these classes for Pallium India. It's nice to see pain and palliative care coming up. And even today when I teach interns come into the OT, I acquaint them with pain because I sensitize them to pain so that as they go on in their career, they will also be sensitive how to handle pain. It is just not a physical sensation, but an emotional experience. And in fact, it's a biopsychosocial phenomenon. So I would like everyone to know what is pain and to, not just treat it from one angle, but to treat it from all angles. So with that, I'd like to share my screen. 1 minute. I think I've got it.
Yes, we can see, madam.
Yeah.
You can go ahead.
Okay, I'll just. So this talk would be, let me just see. So the broad outline of my talk would be the basics of the WHO ladder, the step 1 and 2 drugs of the ladder, the adjuvant drugs that we use in the ladder, and the drugs for neuropathic pain. So this WHO analgesic ladder was devised way back in 1986. And it is a step ladder approach to treat pain. I would not say cancer pain. It is used to treat all kinds of pain, especially cancer pain. And it has been, it is met with a lot of success that even 30 years later, people are still using the WHO analgesic ladder. In fact, today there was an MD exam going on in my institute, and in the paper, one of the questions was the WHO analgesic ladder. So you see, this is the it is so relevant even today, although it was devised way back in 1986. So it is a stepwise approach to treat cancer pain depending on the severity of pain. Prior to the ladder, that is prior to the 80s, people were dying with unnecessary pain because there was a lot of hesitancy regarding the use of strong opioids because of the stigma associated with prescribing and taking opioids. Even relatives felt that their patients will become addicts if they take strong opioids. And there were a lot of drug regulations. So even the procurement of these drugs was difficult. And storing it for the pharmaceutical or the chemist also was very difficult. So there were hurdles at every step. And because of that, people were not being prescribed or administered morphine and drugs like that. But when the WHO itself made that this was the step 3 of the ladder, it actually legitimized the use of opioids. And subsequently, it's been a long journey since then, but now it is much more easy to administer morphine. And also a lot of myths surrounding morphine is also being dispensed with nowadays. And there is, people are open to taking the strong opioids. Now, I'll start with the case scenario. A 35-year-old father of 2 young kids, he had squamous cell carcinoma of the right upper lobe of the lung. The pain was a deep-seated gnawing pain in the right shoulder with burning and tingling in his right arm. He was unable to sleep at night, and the pain score was a numerical rating score, NRS, in the 4 in the day and 6 at night. At the end of this discussion, we will discuss how we manage this pain, this case. So before we know the details of the ladder, it's very important to know about the comprehensive assessment of pain, which I'm sure has been dealt with in the earlier class. But just as a recap, if you can remember the mnemonic PQRSTU, in which it's easy to assess pain with using this mnemonic. In this, I will focus on the severity of pain because this is what is used for implementing the ladder. It's important to know the intensity of pain. And the second thing we need to know is that is the pain nociceptive or neuropathic, or is it a combination of both, which is mixed pain? These two things we have to know, because only then we can apply the ladder in a proper manner so that the patient has a good outcome. That is a relief of pain. Now, in the ladder per se, it's a 3-step ladder. The step 1 is, in the step 1, you use to treat mild pain or pain with an NRS of less than 4 or 5 maximum. So in this, we give a non-opioid analgesic along with an adjuvant if necessary. The non-opioid analgesic could be either paracetamol or NSAIDs. And if the patient is not getting relief with step 1 drugs, then you move up the ladder to step 2, which is used for treating moderate pain or pain with an NRS score of, say, 5 to 7. In this, you just add a weak opioid to the already giving regime. That is, you just add the weak opioid to the non-opioid. Again, an adjuvant can be added if necessary. If the patient is not getting relief with this also, then you move up the ladder to the 3rd step, which is you substitute the weak opioid with a strong opioid, along with a non-opioid with or without an adjuvant. So this is a basic 3-step ladder. Using this ladder, nearly 71 to 75% of cancer patients can get satisfactory relief of pain. What are the salient features of the ladder? 3 things that you need to know is it's given by mouth, by the ladder, and by the clock. Now, by mouth means the oral route is a standard route for administration of all the drugs, especially even the strong opioids. So that is a huge advantage because It can be given by the caregiver at home, very suitable for home care, or if the visiting nurse, the palliative care nurse can give the drugs, or the patient is, you know, intelligent and well-oriented, even the patient can take it themselves. So this is a big advantage. You don't have to go to hospital to take any of the drugs. Like it doesn't have to be given by the parental route. The second important feature of the ladder is that it's given by the ladder. That means usually you start with step 1, and according to the severity of the pain, you move up the ladder. But sometimes when the pain is very severe, you can omit one step in between, or you can start with step 3. That will be dealt with when you're doing the step 3 drugs. That is, you do a morphine titration, and then you can start off with morphine directly if the pain is very severe, agonizing pain. The third important characteristic of the ladder is it's given by the clock. See, our aim is to produce round-the-clock analgesia and not cause peaks and valleys, right? Otherwise, the patient will again feel the pain, then again you give the drug. So the aim to get satisfactory pain relief is to have a continuous pain relief, or an NRS score of less than 3 or 4. 3, and it should be less than 3. So for that, you have to give it according to the duration of action of the drug, and not on a PRN basis. Because if you give it on a PRN basis, you have what is called a breakthrough pain. So this can vary from drug to drug. So it's important to know the half-life of the drug. So if you're giving morphine, it has to be given every 4 hours. If you're giving paracetamol, it has to be given every 6 to 8 hours. If you're giving a COX-2 inhibitor like Nucoxia, then you have to give it only once a day. So it all depends upon the half-life of the drug. So this has to be clearly spelled out to the patient, that do not wait for the pain to come back to take the drug, but just make a chart and go by the clock and give it according to that. Another important characteristic of the ladder, it is individualized to the patient. So the right dose is the one that relieves the pain. Our objective is to relieve pain and not to worry about the dose that you're giving, because you are anyway going to titrate and go slowly up, So in one patient, you can get relief with 30 milligram morphine. In another patient, you may have to give 300 mg morphine, but you've reached 300 only by gradually going up. You don't start off with that dose. But for that patient, 300 is the one that is relieving the pain. So it is, the dose is the one that relieves the pain. And also you have to tell them that supposing in case of morphine, if the pain comes back within 4 hours, what do you do? How do you treat the breakthrough pain? All that has to be specified and individualized to that particular patient. Then there is the use of adjuvant drug at every step of the ladder. So I'll be talking about it in the latter part of my presentation, in which why do you give adjuvant drugs? So that I will talk about later. And important thing is attention to detail. So we should take care when we see the patient, what is the age of the patient? Is it an 80-year-old man, or a 5-year-old boy, or a 25-year-old man? Or what is the body weight of the patient? Is it an adult can be 40 kg or he can be 140 kg? Okay, so it all depends upon the body weight of the patient also. And also the comorbidities. Does he have renal dysfunction? Does he have liver disease? Does he have any CNS problems? What are the drugs that he's taking? All that has to be factored in when you're prescribing the drugs according to the ladder. So the advantages of the ladder, why has it stood the test of time? First of all, it is simple, easy to understand. It is a validated tool. That means it has been proven to be effective when you give it in that prescribed format. It's also very cost effective. Drugs like morphine or paracetamol or non-steroidal anti-inflammatory are very inexpensive drugs. So it is very cost effective, not expensive. And it can be implemented across the world, even in the lesser developed countries. well suited for home care. And it is also applicable for treating acute pain like post-operative pain or pain due to trauma, and also for non-cancer pain as well. So it is a very versatile ladder. That's what I mean by saying that it's applicable for all kinds of pain. There can be some modifications, like I told you. Sometimes you may have to bypass the steps and go up to step 3, or sometimes you can even start with step 3 also if the pain is very severe. And occasionally we may even have to add a 4th step. That is done invariably to treat a crisis of pain which is not responding to even the strong opioid drugs. So this was somewhere in 2000 that this ladder was modified, in which the 4th step was also added for that 10 to 15% of patients who do not respond even to the strong opioids like morphine. So that's what is called intractable pain, and we'll deal with that in another class. So what are the step 4 modalities that we are using? We can use nerve blocks, or we can use epidural injections, or a patient-controlled analgesia, or neurolytic blocks, or spinal cord stimulators, or intrathecal opioids. Okay. And so, like I said, it can be given even earlier, but invariably it's given for pain that is not responsive to the WHO analgesic ladder. So let us come to step 1 drugs. The step 1 drugs are the paracetamol, which is also called acetaminophen, and the non-steroidal anti-inflammatory drugs. And they can be combined with the adjuvant drugs used to treat mild to moderate pain. So paracetamol has basically a central action. It inhibits the enzyme cyclooxygenase, or COX, in the central nervous system. Please remember that it has no effect on the peripheral COX. And because of that, the side effects are much less as compared to the NSAIDs, because NSAIDs acts on the peripheral COX. So it is called basically an antipyretic and analgesic action. It does not have an anti-inflammatory action. So that is a drawback of paracetamol. How do you give it? The dose is between 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day, but the daily dose should not exceed 4 grams, and a single dose should not exceed 1 gram. The normal dose is around 650 mg every 6 hours. Now we have sustained release tablet of 1 gram, in which 300 is released immediately, and the remaining 700 is released over a period of the next 12 hours. So that can be given even twice daily. These preparations are now available even in our country. It can also be given by the infusion, that is paracetamol infusion. We can give 1 gram every 6 hours or every 8 hours. The rectal route can also be used. Suppositories are available, and that is given generally when the oral route is not feasible, as in head and neck cancer, or when the mouth opening is not adequate, or when the patient is on, not able to swallow, or having maybe some intestinal obstruction or something like that. Then you can give it even through suppositories. It is very safe for pediatric. The dose is 15 mg per kg every 6 hours. Remember that toxicity occurs in doses of more than 90 milligram per kg per day. Now, what is the numbers needed to treat of paracetamol, or what is called NNT? Now, this term is important because it will tell you about the efficacy of a particular drug. So, what is NNT? It is a number of patients who receive the drug for one to have 50% relief over the next 4 to 6 hours compared to a control. So the lower the NNT, the more efficacious is the NNT. In case of paracetamol 650, the NNT is 5. That means for every 5 patients, one will have good relief of pain. So if you compare it to the other NSAIDs like ibuprofen or diclofenac, it's not that efficacious. That has a lower NNT. What are the advantages of paracetamol? First of all, I told you that because it does not act on the peripheral cyclooxygenase, it's a good side effect. It has a good safety profile, no adverse effect on gastric mucosa, so well tolerated by patients with peptic ulcers or with acid peptic disease. no adverse renal effect, safely can be given in patients with renal dysfunction, no effect on platelet function. So platelet aggregation is not affected. It is tolerated by patients who are allergic to NSAIDs and aspirin. So it can be given to those people, and it does not affect plasma uric acid level. So it can be given to patients with gout as well. But the drawbacks are that it has to be given every 6 hours. It has no anti-inflammatory action. It has a potential for hepatotoxicity, but that occurs when you give high doses or in those with liver dysfunction, or those who are taking excessive alcohol, or when the body weight is less than 50. In such cases, you can reduce the dose. Like in a patient whose body weight is less than 50, just give 2 grams a day. Or in those with liver disease, you can restrict the dose to 2 to 3 grams per day. It can be given in those patients. So it's not an absolute contraindication. So in cancer pain, it's become the mainstay drug because of its safety profile and because it has an opioid sparing effect. But when you add paracetamol to the opioid, then you can actually reduce the dose of opioids that you're giving. And so it can be given at every step of the ladder, step 1, step 2, and step 3. Now, let's move on to the non-steroidal anti-inflammatory drugs. Now, unlike paracetamol, this acts by inhibiting the enzyme peripheral cyclooxygenase. Now, this is a very important step in the arachidonic acid cascade after tissue injury, which produces the tissue and the inflammatory prostaglandins. They are the mediators of pain and inflammation, the prostaglandins. And they mediate pain through a phenomenon called peripheral sensitization, which amplifies the pain. Okay. So it is particularly useful in nociceptive pain, which is associated with inflammation. Now, if you look at this chart, you see that here there is a tissue injury. And when there's tissue injury, there is a breakdown of the cells and there is a release of a lot of tissue byproducts and inflammatory mediators like prostaglandins, CGRP, bradykinin, histamine, and substance P, etc. Also the excitatory mediators like glutamate and the cytokines and all. Now, when this happens, this is a nociceptor. Okay, this is a peripheral afferent neuron, and this is the nociceptor, that is the nerve endings in the tissue. So when these inflammatory mediators are released when there's a tissue breakdown, it forms a sort of a soup, inflammatory soup, which sensitizes this peripheral nociceptor. That is why it's called peripheral sensitization. And because of this, it amplifies the pain signal. So the COX inhibitors, like the COX-2 inhibitors, COX inhibitors like NSAIDs, they actually act by the anti-inflammatory action by decreasing the release of the prostaglandins. It inhibits the prostaglandin release. So this extent of the peripheral sensitization depends on the extent of tissue damage. For example, if it's a simple cut, it's not so bad. But if there's a crush injury or there's extensive like cancer pain, when there's a lot of inflammation, then the peripheral sensitization is more. And that is mediated by these inflammatory mediators. Okay. So, like I said, the tissue injury causes the release of phospholipids, which releases the arachidonic acid. And then there is the COX inhibitor is actually induced. Once there's a tissue damage, this enzyme is released, and this causes the conversion of arachidonic acid into the prostaglandins. And it's the prostaglandins that mediate the pain and the inflammation. But we must remember that this is mediated by a cyclooxygenase called COX-2. There is also COX-1 that is existing in the body in normal tissues, not in injured tissue. Injured tissue, you have COX-2. In normal tissues, you have COX-1. This is the constitutive or the housekeeping enzyme, which mediates the physiological responses or the homeostasis of the body by protecting the stomach, the kidney, and facilitating platelet aggregation. whereas COX-2 occurs only when there's inflammation. So if you remember this, then we will know how the COX enzymes are inhibitors are acting. So there are two types of COX inhibitors. The non-selective, which is interfering both with COX-1 and COX-2, and you have the selective COX-2 inhibitor, which interferes only with COX-2 and does not interfere with the action of COX-1. So what are the non-selective COX inhibitors? That is, they are now having the good effect of inhibiting the COX-2, but it also has the adverse effect of inhibiting the COX-1. So it will have the adverse effect on the stomach and the kidney and on platelet aggregation, etc. So these COX inhibitors are basically the salicylates like aspirin, the propionic acid derivatives like ibuprofen, naproxen, ketoprofen, the diclofenac, piroxicam, ketorolac, indomethacin. These all come under the non-selective COX inhibitors. So, like I said, they're inhibiting both COX-1 and COX-2. Because of inhibiting COX-1, it exerts the adverse effects. That is all these, the GI side effects like bleeding, hypersensitivity reaction like urticaria, bronchospasm, angioedema, and even the adverse renal effects. But by inhibiting the COX-2, it has the anti-inflammatory, analgesic, and the antipyretic effect. So the non-selective NSAIDs is a double-edged sword with both adverse and beneficial effects. That should be kept in mind when we're prescribing these drugs. So some of the examples of the non-selective COX inhibitors are ibuprofen. It is given in a dose of 400 mg every 6 hours. The NNT of ibuprofen is 2. That means it's a good analgesic. For every 2 patients, 1 will get good relief of pain. Then you have naproxen. I'm just discussing only the prototypes. There are others, like I mentioned earlier. So naproxen is again given in only twice daily dose, because that's the half-life of the drug. And its NNT is 2.7, which is also considered a good analgesic. So when you look at the side effects of the NSAIDs, then you must remember that the renal dysfunction can occur. It can cause the gastrointestinal effects. It can cause hypersensitivity reactions. This is all because of the COX-1 inhibition. Now coming to the COX-2 inhibitor, they are the ones that only block the COX-2 enzyme and they do not interfere with the COX-1 action. So some examples of this are etoricoxib. The brands available are Nucoxia and Etoshine. It's again given only once a day dose, either 60 milligram, 90 milligram, or 120 mg. Then we have celecoxib, which is given 100 to 200 mg twice daily, or diclofenac. Diclofenac sodium is functionally like a COX-2 inhibitor because it does not have the adverse gastric effects. So it is given in a dose of 50 mg every 8 hours, a maximum of 150 mg per day. Its NNT is very good. It's 2, just like Brufen. That means it's a very good analgesic. Now, the NSAIDs can be given by other routes as well. It can be given topically, we have gels and creams and sprays available. That causes less side effects like toxicity. And the drugs that are used for these gels are ibuprofen, diclofenac, piroxicam, ketoprofen. Then you have transdermal NSAIDs. That is, diclofenac patches are available of 200 mg patch, and that effect lasts for 24 hours. Now, sorry, this Justin is actually a suppository. It's a glycofenac suppository. It's not a transdermal. That's a mistake. This can be given as a suppository that can be given for children and mainly for children. Now, the question we need to ask are selective COX-2 inhibitors safe as compared to the non-selective inhibitors? Because they are not affecting the COX-1 enzyme. So they are safe for the GIT. But where the renal damage is concerned, it is as bad as the non-selective NSAIDs. So don't think that the COX-2 inhibitors are safe in patients with renal dysfunction. But the flip side is that it is actually prothrombotic. So in patients, it can precipitate myocardial infarction and stroke, the COX-2 inhibitors. And because of this, one of them, the rofecoxib, was taken off the US market in 2004 because of the risk of MI. So in such patients, you avoid COX-2 inhibitors, those who are at risk for thrombotic events, and you can prefer to give brufen or naproxen in the high-risk cardiac case. So if you look at the risk factors for NSAIDs toxicity, we have to remember that when you're giving the NSAIDs for GI toxicity, and all for everyone, advanced stage is one of the contraindications. Okay. Be very careful when you're giving it to elderly people. Then, if those with upper GI symptoms and bleeding, you must avoid NSAIDs, and those who are on steroids and anticoagulants. For renal toxicity, again, we have to be very careful in dehydrated patients. So hydration should be maintained when you're giving NSAIDs, otherwise they can go into acute renal injury. And also when the creatinine clearance is very low, you must avoid the NSAIDs. And then for the people who have a risk of cerebrovascular or cardiac events, like those with diabetes, hyperlipidemia, history of TIA or stroke or angina, you must avoid the COX-2 inhibitors because of the prothrombotic effects. Having discussed step 1, let us move on to the step 2 drugs. The step 2 drugs are the weak opioids, but they are not controlled drugs, unlike strong opioids. That means it is more easy to procure them. So they are given for pain of moderate intensity in a VAS of, say, NRS of 5 to 7, which are not controlled by step 1 drugs. The examples that I will talk about are tramadol and tapentadol, because that is what is available in our country. Now coming to tramadol. Now tramadol is a weak opioid. It has a dual method of action. It's not just a weak opioid because it is inhibiting the mu receptors. And because it's weak, there is less tendency for respiratory depression, and the addiction potential is also less as compared to the strong opioids. But it also has a non-opioid method of action. That is, it blocks the presynaptic reuptake of serotonin and norepinephrine. And that is acting on the descending inhibitory pathway of pain. So the descending inhibitory pathway of pain is particularly, it's good when you want to treat the neuropathic pain. So this is very effective for neuropathic pain. It is a prodrug. That means it is converted to active metabolites for its analgesic action to occur. And that is through the enzyme cytochrome P450. And the analgesic combination of tramadol and paracetamol is widely used as a step 2 drug. The advantage of tramadol is it's got high oral bioavailability. Its plasma half-life is around 6 hours. Okay, so we have to give it every 6 to 8 hours. The oral dose is pretty potent. It is 1/10 as potent as morphine. So when you want to convert tramadol to morphine, you have to divide the tramadol dose by 10 and you will know the equi-analgesic dose of morphine. Like if you're giving 400 mg tramadol and you want to convert to morphine, then you have to give 40 mg. So the dose is 50 to 100 mg every 4 to 6 hours, with the maximum dose not exceeding 400 mg. Nowadays, we have sustained release formulation in which you can give it twice daily. The side effects of tramadol are nausea, vomiting, dry mouth, constipation, dizziness, sedation. There is a risk of seizures, but that occurs when you're giving a dose more than 400 mg or as a rapid IV injection or with drugs that lower the seizure threshold like the tricyclic antidepressants or the SSRIs. So when you're giving tramadol IV, please remember that you tell them to give it as an infusion over 15 to 20 minutes. You can even combine it with an antiemetic also. Now, tapentadol, that is the other step 2 drug, which is a weak opioid. But actually, the opioid binding studies are showing that it is a strong opioid. Although in the WHO analgesic ladder, we are classifying it as a weak opioid. Because 75 mg tapentadol per orally is equal to 30 milligram of morphine. So, which means that it is even a little stronger than tramadol. Now, this action is similar to tramadol. It is a mu receptor agonist, so it acts on the opioid receptors. It is also acting on the descending inhibitory pathway of pain by preventing the reuptake of serotonin and norepinephrine. It's not a prodrug. That means, unlike tramadol, it does not have active metabolites. The dose is very similar to tramadol, and again, sustained release formulations are available. But the side effect profile is much better as compared to tramadol, with less risk of seizures. But you should avoid it in patients with severe renal and hepatic dysfunction. So if you look at some combinations that we can use for cancer pain, remember that never use two drugs of the same category for treating pain. For example, we do not combine COX-1 and COX-2 inhibitors. So try not to combine brufen with a drug like a nucoxia, that is the etotoxin. Because, sorry, not etotoxin, don't combine it with a brufen with a selective COX-2. That is etotoxin. Or you don't combine a weak opioid with a strong opioid. Either you give a weak opioid or you give a strong opioid. But these are the analgesic combinations that are favorable. That is paracetamol with NSAIDs, with morphine, or with tramadol. They are favorable combinations. Now, I'll move on to neuropathic pain. Now, it must be remembered that cancer pain is variegated. It is not just nociceptive. That is, it's not just due to tissue injury. There's a very strong neuropathic component. That is, 40% of cancer pain can be neuropathic. There could be bone pain if there are bone metastases. There could be bowel obstruction. There could be muscle spasm. So that is why we add the adjuvant drugs to treat all those kinds of pain as well. So adjuvant drugs have analgesic properties, but the primary indication is not for pain. They are called co-analgesic because they are administered along with other analgesic drugs. Now, if you classify the adjuvant drugs, you have specific adjuvant drugs like those treated for neuropathic pain or bone pain or bowel obstruction pain or musculoskeletal pain. You have specific drugs. Or you have multi-purpose drugs like antidepressants, corticosteroids, alpha-2 agonists. They can be given for a wide variety of pains. Now, to remember know about neuropathic pain, we should know about this basic diagram. That is, a nociceptive pain is what is occurring at the site of tissue injury. Anything beyond this in the peripheral nerve or in the spinal cord or in the brain or in the ascending pathway, it's all neuropathic. So neuropathic pain is caused by a disease or lesion in the peripheral or the central nervous system. But very often the pain can be mixed with both nociceptive and neuropathic combinations. So why does neuropathic pain occur in cancer? It could be because of direct invasion or compression of the nerve, or it could be the treatment of cancer itself can cause neuropathic pain. For example, we have the chemotherapy-induced peripheral neuropathy. The chemotherapy agent is also destroying the peripheral nerves and causing a peripheral neuropathy. Or you can have radiation-induced peripheral neuropathy, or it could be because of the surgical excision of the cancer causing injury to the nerve, which is causing neuropathy, or it can even happen in the cancer survivors. They have been treated of the cancer, but because of the permanent nerve damage, the neuropathy is still present in these patients. Normally, after stopping the chemotherapy drugs, the neuropathy usually subsides in a few months' time, but sometimes it can persist even for years. So what is the first line drug for treating neuropathic pain is the anticonvulsants. Why is it used for treating neuropathic pain? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitability, and the anticonvulsants are actually dampening the neuronal excitability. So the commonly used drugs are gabapentin, pregabalin. How do they act? It prevents the influx of calcium into the presynaptic neuron by acting on the alpha-2 delta subunit. And because it is preventing the calcium influx, there's less release of neurotransmitters and less postsynaptic neuronal excitement. It can also act on the sodium channels and the GABA-mediated inhibition, but the main action is the calcium influx that it is preventing. So the drugs are gabapentin and pregabalin. We know the effect. It is very advantageous in neuropathic pain, but it has side effects like somnolence, dizziness, ataxia, fatigue, weight gain. So this has to be explained to the patient when you're starting. And you, again, gabapentin is less expensive, pregabalin is more expensive. Pregabalin can be titrated in just 2 to 3 steps, whereas gabapentin, you use multiple steps to reach the desired level. Now, topical gabapentin is also available, and even topical capsaicin are available to treat neuropathic pain. Okay, so topical drugs at site of neuropathic pain, you can also give it. Now, the other first line treatment of neuropathic pain are the antidepressants. So both anticonvulsants and antidepressants are the first line treatment for neuropathic pain. Now, remember that it is an antidepressant, but the analgesic effect is occurring earlier and at much lower doses than that is required for the depression. But it still takes a week for its analgesic action to kick in. So it's very useful in cancer because along with the neuropathic pain, it is also treating the depression, anxiety, insomnia, etc. How do they act? They inhibit the reuptake of norepinephrine and serotonin, and thus activating the descending inhibitory pathway of pain. So the most important drugs that we are giving the antidepressants are the tricyclic antidepressants, the selective serotonin reuptake inhibitors, and the serotonin norepinephrine receptor inhibitors. Now, some other drugs are also available, like the NASA drugs, like mirtazapine, or the atypical psychotics like quetiapine, risperidone, olanzapine. But the ones that we are most commonly using are the first 3 categories. So, if you look at the tricyclic antidepressants, we have amitriptyline, nortriptyline. Then among the SNRI, we have the duloxetine and the venlafaxine. Among the SSRI, you have the escitalopram, citalopram, and paroxetine. But if you look at the analgesic effect, this is has most analgesic effect, but the side effects are much more. Whereas SNRI has got little less than tricyclic, but more than SSRI. SSRI is mainly for anxiety and depression, less analgesic. So this is again telling the same thing, you know. TCA has got more than SNRI, more than SSRI. And side effects, TCA has got more side effects as compared to the SNRI and the SSRI. Now, we must know the side effects of the tricyclic antidepressants. The CNS, it causes the somnolence, drowsiness, mental clouding, and you must remember the anticholinergic or the antimuscarinic effect of TCA. It can cause dry mouth, acute angle glaucoma, it can cause cardiotoxicity, urinary retention, constipation, orthostatic hypertension. That's all because of the antimuscarinic effects. So you must be careful to avoid it in patients with cardiac conduction defects, those with benign prostatic hypertrophy, and those with narrow angle glaucoma. It's contraindicated. Now, if you look at the SNRI, again, the side effects are the same, more or less: somnolence, dizziness, constipation, anorexia. So we have to be very careful in patients with hepatic or renal insufficiency. And the doses are given over here. Amitriptyline, when you're giving, you start with a dose of 10 mg, give it at night. Okay? And increase it every 3 to 5 days till you get the optimal level of 50 milligrams or 100 milligrams. Nortriptyline, same dose. Venlafaxine, duloxetine. Duloxetine, you can start with 20 to 30 mg and then move on. And venlafaxine, start with 37.5 and move on. Okay. Anticonvulsants, again, gabapentin, we usually start with 100 mg at night and then 300 mg, and then you can go up to even TDS doses also. Pregabalin 75 mg or even 50 mg is now being given, or you can then gradually move up to twice daily. Remember, all these doses should be adjusted in the medically ill patients with comorbidities or those with elderly people or those who are emaciated. You have to adjust the dose according to them. And duloxetine has been particularly useful in patients with chemotherapy-induced peripheral neuropathy. It improves the pain, function, and the quality of life. So patients are receiving duloxetine for the 5 weeks, had lesser pain as compared to placebo treated. So it has now been added in the updated guidelines for the initial treatment of painful chemotherapy-induced neuropathy. So the other drugs used in neuropathic pain are ketamine. It acts on the NMDA receptor, which is there in the dorsal horn of the spinal cord. But it has got side effects like dysphoria, hallucinations, nausea, vomiting. These can be prevented by adding a benzodiazepine or a haloperidol. You can prevent these side effects. It's given in a wide routes of administration. IV, IM. Excuse me, I'll take about 5 minutes more if that is okay. So it can be given IV.
Should be okay,
IM.
madam. Go ahead, and then we have the case presentation. And so far, there's no message in the chat. We can have the discussion after you finish.
Okay.
Thank
so
you.
it's given by a wide variety of routes. IV, IM, subcutaneous, oral, sublingually, etc. Its IM bioavailability is very good. At 5 minutes, you have 90% available. So it's very good even by the IM. Now, ketamine is actually an anesthetic, but it is an analgesic in the sub-anesthetic doses. So in low dose, like 0.2 to 0.5 milligram per kg, it is actually it has analgesic effects. It can also be given as a subcutaneous and intravenous infusion in a dose of 50 to 100 mg per day, maximum dose of 200 mg. So in difficult pain or intractable pain, you can give what is called a burst ketamine infusion. I'll discuss that when we are discussing difficult pain. The other drug which is given for local for neuropathic pain is local anesthetics. This acts by inhibiting the sodium channels, and it's particularly useful for the severe intractable neuropathic pain. How do we give it? We give it as a local anesthetic infusion. You calculate the body weight, the dose of Xylocar, that is 5 milligram per kg, add it to 500 mg of normal saline, and give it over 1 hour intravenously, keeping a cardiac monitoring and monitoring for CNS effects. So it's done as a daycare procedure. It has been used for treating non-malignant neuropathic pain. Now, local anesthetic patches are also available. It's called lidocaine patches. 5% lidocaine patches are available now in India. We can apply up to 3 patches per day, but only thing is you should keep it for 12 hours and remove it for the next 12 hours to avoid local anesthetic toxicity. Now, the other drugs used to treat neuropathic pain are topical capsaicin and topical gabapentin. I mentioned that earlier. So if you look at the neuropathic pain ladder, the first line is amitriptyline, gabapentin, pregabalin, duloxetine, and lidocaine patch. The second line are the opioids like methadone and tramadol. And the third line are ketamine and capsaicin patch, etc. Now coming to the adjuvants, like the multi-purpose drugs like steroids. Now steroids is called multi-purpose because it can be given for a variety of pains, neuropathic pain, bone pain, cerebral mets, and even for hollow viscous obstruction. So if you look at the steroids that are available, we have hydrocortisone, prednisolone, dexamethasone. Dexamethasone is a preferred drug because it's got a very potent anti-inflammatory action. Excuse me. It's got 25 to 50 times more anti-inflammatory effect than hydrocortisone. Also, it has a very long half-life. So It can be given once a day dose. Its half-life is 36 to 56 hours. So it's a first-line drug in cancer for whatever these conditions I mentioned. It has got anti-inflammatory effect with less mineralocorticoid effect. So it can be given, but give it night because it can cause, do not give it at night because it can cause insomnia. So this is a dose of dexamethasone that you give for various cancer. Then we have the GABA receptor agonists. So we have two types of GABA receptor. These are GABA are the inhibitory neurotransmitters. So the ones that are available are GABA A and GABA B. Excuse me. The GABA A agonists are the benzodiazepines. Of its clonazepam is used for neuropathic pain, and the GABA B agonists are the baclofen. So this is a dose that you give for neuropathic pain for 0.5 microgram, 500 microgram at night. Can also be used for terminal sedation. The GABA-2 B agonists are the baclofen. That is also very effective in neuropathic pain. Can start with 5 mg and then move up to 10 mg PD or TDS. Bone pain is another very important cause of cancer pain. It's because of the skeletal related events. It could be fracture, it could be the pressure that it exerts on the nerves, etc. It can cause very agonizing pain. So the various agents that we use to treat bone pain are the corticosteroids and the NSAIDs. The other is the bisphosphonates and the denosumab and palliative radiation. Calcitonin in the latest review shows that it is not very effective. So the bisphosphonates, the ones that we use are the zoledronic acid. It acts by blocking the osteoclastic activity and enhancing the bone formation. Okay, so how do we give it? Intravenously, 4 mg in 100 ml of normal saline over 15 minutes, and can give it every month for a year. But it has got side effects, so we should keep in mind the side effects of the bisphosphonates. Denosumab is also given for bone pain. It is more expensive than zoledronic acid, but it can be given subcutaneously with less risk of renal toxicity. And it is superior as compared to zoledronic acid, but it is very expensive. So that is a major drawback. In fact, if you look at the cost, you find that the cost of treatment per month for denosumab is 32,000, for zoledronic acid is only 900 bucks. Then palliative radiation can be done for bone metastasis, particularly when it is focal. So it can cause quite a relief of pain when you give palliative radiation. For malignant bowel obstruction, the various drugs that are given, adjuvant drugs, are the steroids, the octreotide, and the anticholinergic drugs, or you can combine all of them to treat malignant bowel obstruction pain. The other adjuvant drugs are the muscle relaxants, the neurolepts, particularly when there's hallucination and delirium, then various laxatives and sedatives and anxiolytics. So if you look at how they act on this pain ladder, on the pain pathway, you find that the muscle relaxants are acting at this level, the neuromuscular junction. The local anesthetics and the NSAIDs are all preventing the peripheral sensitization. Again, this is a nociceptor. Then the drugs that act on the dorsal horn are the anticonvulsants, antidepressants, opioids, and the NMDA antagonists. And the ones that prevent activate the descending inhibitory pathway of pain are the alpha-2 agonists, the SNRIs, the weak opioids, and the even tramadol and tapentadol and the TCAs. So this is how they act at different parts of the pain pathway. Now, coming back to a case scenario, we know about this gentleman who had the pain because of CA lung. Now, his pain was actually mild to moderate only. He had only 4 in the daytime and 6 at night. But it was a mixed type of pain because he had both pain, which is gnawing, and also he had the burning and tingling in his arm. So it was a mixed type of pain with both nociceptive and neuropathic. It was worse at midnight because, and also he was unable to sleep. So he was also having emotional, social, and financial issues. So having understood this, then we know what to do for this patient. So you can give a combination of step 1 drugs in this gentleman, but because he has more pain at night, you can give a higher dose of paracetamol or diclofenac at night. You can add an anticonvulsant or antidepressant because of the neuropathic pain that he's having. And we can even add a sedative so that he gets a better sleep. And then, of course, we should take care of the psychosocial component for his financial and social and his psychological concerns. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. Its advantages are its simplicity and easy implementation. It can be used all over the world, even in the remotest areas. And it has importantly legitimized the use of opioids in cancer and non-cancer pain. Thank you so much.
Thank you very much, madam. Like, as I started off telling, like yesterday they were having so many queries when we had the introduction session. So mostly pathophysiology, so many excellent diagrams, because generally we say whatever we see stays very strongly. As a joke, I generally say all movie posters and all we see, which stays very well in our heads. So like that, pictures convey a lot, and you had so many, and so much of pathophysiology, everything would have gone in. Just couple of things alone I wanted to add on. Yesterday, I was mentioning, like you mentioned about suppositories, which will be very, very useful, because I think in the case discussion and in many times in the discussion also, they were asking about what are the other ways of giving. So suppositories are very good, both for pediatric and adult, especially in adult patients. If they are bedbound, they can't swallow. Still, paracetamol, diclofenac suppositories are there, which are very effective and useful and can be used. So those are things I just wanted to convey to them, because what we were telling, the queries are being answered today. There are a couple of messages in the chat. Shall I read, madam?
Yeah, I can also go through that.
Okay, okay. When to choose pregabalin over gabapentin? Does the sedative effect of pregabalin restrict its use during the day?
See, you can choose either of them. I use both gabapentin and pregabalin. But if a person is, not that well off, then you prefer to give gabapentin because pregabalin is more expensive. Okay. The advantage of pregabalin is that in just 2-3 steps, you can titrate to the optimum dose, whereas in gabapentin, you have to go a little more slowly. That is one. And the other thing is that you can give it, you start off with a night dose, but then gradually you may have to give it even in the daytime also, no problem. But when you start with the night dose, the body gets used to it, that little dizziness, somnolence, and all will slowly settle down as the days pass. And then you can even give it in the daytime. Gabapentin is given 3 times a day also. And pregabalin can be given twice daily also, no problem. But in the beginning, you always start with a night dose, because you don't want the patient to, completely say that, no, I'm not taking it, I'm feeling dizzy and all. So, and also to avoid the dizziness, I always tell them to take it before 8 o'clock at night. Because by then, the effect will wear off by the morning. Because when you say night, I find patients are saying, we had dinner at 12 o'clock, so I had that tablet at 12. So that is not the way to do it. I say that, no, you must take it before 8 o'clock. Have something small, but take the tablet early. And don't take it late night. That is when the symptoms of ataxia, dizziness, and all become more, and the somnolence and effect. Okay. But you can give it, gradually you can give it even twice daily or thrice daily.
Same, madam. We even in Pallium, what we say 7 o'clock. Even all through my practice.
7
also,
is even better, even better than 8.
Because by 7 next morning, you'll be clear-headed. Okay.
Exactly.
So that we really insist. So generally, as Madam said, I'll say, have the tablet on, take it at 7 wherever you are, and have your dinner whenever you want. So there's no correlation to that. And as you mentioned, Madam, the first thing starting off in the night, leaving on and that night dose for some time, and then adding on, because as clearly it has been mentioned, it takes time. It is not like paracetamol or diclofenac. One tablet in, next minute you won't see the benefit. So if you you have to convey this to the patient, because the patients are going to expect, oh, I've had it, I am going to get some benefit. Especially when they're not getting any benefit, they may be upset. Or no tablet is working for me. See, at the end of the day, we are all human beings. Okay. So our duty to convey these important things is important.
Yeah.
And next question is that,
particularly with tricyclic antidepressants, we must tell them that you wait for 1 or 2 weeks for the effect to come. It's not a magic drug that it'll work immediately, you know. And also we have to start with a low dose. The next question is, how do we prefer between amitriptyline and nortriptyline? Like I mentioned, amitriptyline is a tertiary amine, whereas the other one is a secondary amine. Amitriptyline is more strong analgesic, but more side effects as well. So if a patient is having elderly person who has got, maybe some cardiac issues or some prostatic issues or constipation and things like that, I would prefer nortriptyline. Although if you can give amitriptyline also, but you must explain about the side effect. But nortriptyline, if patients have too many other comorbidities, I would prefer nortriptyline.
And there's one more question also, Madam, about TENS, benefit of TENS and acupuncture in neuropathic pain. That's also there. What is the opinion? What's the view of the use of TENS and acupuncture in neuropathic pain?
Okay. Now, how do they act? First of all, we should know how does these modalities act, like TENS. How do they act? They act by the gate control pathway. So they are stimulating we have got various nerve fibers. Now, A delta and C fibers are conveying the pain impulses, whereas the A beta is conveying touch impulses. Now, when you apply TENS, it's an A beta that is getting stimulated, and that is actually moving into the spinal cord. There's a neural gate, it's a virtual gate, it's not a real gate. But because of the A beta stimulation, the pain fibers are being blocked at the gate. That is how TENS is acting, because it is causing that stimulation, massage, TENS, etc. They are acting by stimulating the A beta fibers and closing the gate and preventing the pain impulses to go. So that is how TENS is acting. Now, acupuncture is different. Acupuncture acts also by the gate control, but it also acts by other mechanisms. But what I want to tell is, for neuropathic pain, I do dry needling. That is much more effective for neuropathic pain than acupuncture. Okay. And dry needling, particularly for pain due to lumbar degenerative disease like diabetic neuropathy, etc. Dry needling is very effective. And dry needling is acting by releasing the muscle spasm and allowing the nerves to breathe. And also, because of the muscle spasm, there's a lot of hypoxia in that center. So by needling, you're actually relieving that and allowing more circulation and allowing the trapped inflammatory mediators to come out. So dry needling is effective for neuropathic pain. I'm not sure how much acupuncture is effective for it.
These all will have individual element also, individual benefit. So they're all worth giving it a try, okay? Because there's no box standard in all this, okay? Because especially like, for example, if I'm just giving examples with the patients whom we have had, headache, acupuncture, for some people it works. Okay, so that's what, as I say, no one size fits all doesn't work with human beings at all. Okay, and especially with issues. So you have to see what works for that particular patient. So these are all non-pharmacological methods. There are umpteen. And one important thing, as ma'am mentioned, is the gate control theory. Inhibitory pathway is what is utilized in that. Just we say that rubbing the hand when a child falls or when you fall, you automatically do that rubbing and then you get some relief. No, so that also is the inhibitory pathway effect only. So those are things. They are all other modalities which are available. If the availability or option is there, worth trying. TENS is something many patients use and they get some benefit out of it. And madam, there are some more.
How does tramadol have neuropathic pain? I told you, no, tramadol acts on the descending inhibitory pathway of pain also. It's also a mu agonist, but it also acts on the descending inhibitory pathway of pain. That means it's preventing the reuptake of serotonin and norepinephrine. That is how it is having the effect on neuropathic pain. Just like your SNRI. SNRI drug, what are they doing? They're inhibiting the reuptake of serotonin and norepinephrine. Tramadol also has that effect. That is how it is having the neuropathic.
And one more question is diclofenac dose for PR, they've asked.
Okay. I'm not very sure of it. The suppository is called Justin, but the dose, I think it must be coming in different strengths, no?
50
Maybe
and 100 milligrams.
50 and 100 mg strength.
50 and 100 milligrams are available. And you can use, like, see, same 100 milligrams. You have to try because you are going to use it along with something else. So 50 or 100 milligrams you can try and then see the response and take it forward. This all depends on the patient whom you're using it for, who cannot swallow and things like that. So it is available as 50 and 100 and you can use them in that way, 50 milligrams twice, or you can use 100 milligrams once and see the response and take it from there. Something else, how do we taper off the pregabalin?
Tapering off
medication.
Again, we should do it slowly. We cannot just stop. Patient is getting 75 mg twice daily. We can't just tell them just stop all the drugs. You know, I never do that. Whenever I'm giving neuromodulators, I never give it. So I start off by saying take it at night. Then after that, take it alternate day. And then you can stop, you know. It's always any of these neuromodulators should always be tapered off.
See,
because as you're tapering off, you see whether pain is recurring or not also. So if the pain is coming back, then you have to go back to the old regime. I have in case anyone is interested about the gate control, I've got a slide to show that. Would you like that? But is there enough time?
I was also trying to get that. Please go ahead, madam. I was also.
Then just give me a minute. I'll just open that presentation. Okay.
Same. I too did the same thing. I found one and I've kept if you want. You go ahead, please. When should we prefer diclofenac patch over oral medication? No, only when, see, diclofenac patch or diclofenac suppositories when patient can't swallow. Like especially in patients who are immobile, have difficulties in swallowing or some issues like that, you can use these type of things. And also like sometimes pain also, no, it depends, like very localized, that type of pain you can use.
Radha, can you see the slide? Can you see the slide?
We can't, you're not sharing yet.
Okay. Let me share it then. 1 second. I'm sorry. I just sometimes get a little confused how to do this. Sorry. Okay. Now I go to share screen.
Yes, madam.
I go to share screen and then I'll open that presentation. Here. Okay, now can you see it?
Yes, it's coming up. Yes, we can.
Okay, so I'll just show the slideshow. Current slide. Okay, so this is the gate control theory of pain. So this is the spinal cord and there is something like a gate over here. So when you have an injury over here, you have the A delta and A beta fibers that are getting stimulated. But what they do is they actually open the gate, and also things like anxiety, depression, and inactivity, all that also opens the gate. But when you want to inhibit the pain by stroking, massage, tense, and all this over here, it actually stimulates the A beta fibers and it closes the gate. Similarly, activities like distraction, relaxation, meditation, yoga, all that also helps close the gate. So, see, if you look at the thing, it's something like this. See, this is the pain that is going through the C fiber. Okay, it is entering the spinal cord and then going up the projection neuron to the brain. Now you have the A beta fibers also, which are mediating touch. And there are something called inhibitory neurons here in the spinal cord, in the dorsal horn. So, but when you stimulate the A beta fibers, it is stimulating this inhibitory neuron, which is then inhibiting the projection neuron, so that this is blocked and this is the one that is going forward. So stimulation of A beta will activate this inhibitory interneurons in the spinal cord, which is going through the projection neuron upwards and blocking the C fibers from going. So this is the mechanism of the gate control path. Okay, is that clear?
Exactly. This the same. The second picture is what I also brought it up because it's explaining clearly how the A beta fiber stimulation gets the gate closed and the pain is not perceived. So these are exactly all as Madam said. And one more thing, Madam was mentioning about dry needling and increasing the oxygen. So they say one of the other things which we also tell patients is just meditation. There is very clear evidence to say that like breathing, pranayama increases the oxygen stores. And it's a very good antioxidant. So these are things which we have to explain to the patients. So 5 minutes, 10 minutes of good, deep, equal inhalation, exhalation improves the oxygen and mitochondria oxygen levels improve. So end of the day, all entire muscle, the whole oxygen availability increases and that also gives benefit. So there are multi-pronged, multimodal management is what will work.
Yes.
Okay, madam, we'll go on to the case discussion.
Is always, okay, please continue.
It is multimodal, isn't it, madam? That is how
yes.
Okay. And we have some more sessions. So as from yesterday, I'm telling the same thing. Don't think I'm repeating like a parrot, but it is the same. Like because you have 3 sessions for pain. So, but so that all pros, cons, and possibilities, what you would face is all thrown at you so that you feel comfortable. Okay, Sri Priya, I think I'm going to hand it over to you to go on with the case presentation, please. Hello, Sri Priya, is she there?
Yes, ma'am. Just a technical glitch.
Okay.
We are working on that.
Okay. No problem. I just made sure you are there. That's all.
Madam, can I ask something? Hello?
What is that?
Anisha.
What is that? You want to ask anything?
Yeah, ma'am, can we get the recordings of the video? The classes that we are receiving, can we get the recordings of them as well so that we can listen it later also?
They will all be uploaded.
Yes,
They
yes.
will all be uploaded.
No, that's why they are recorded, no?
Okay.
Dr. Gora?
Am I audible?
Yes, sir.
Okay. Good evening, respected faculties and all the participants. Myself, Dr. Malay Kumar Ghoda. I'm working as a medical officer at Eastern India Palliative Care. So, this is a case of a 69-year-old male. He was diagnosed as non-small cell lung cancer of his right lung. His presenting complaint was right-sided chest pain for the last 1 year, and along with cough with hemoptysis for the last 6 months. Coming to the next slide. The patient was apparently well 1 year back. Then he developed right-sided chest pain of mild intensity. It used to occur anytime throughout the day, persisting for a few minutes and resolved at its own initially. But for the last 6 months, the severity has been increased with some occasional exacerbation. The pain sometimes radiates to his back also. It got forced during coughing or taking deep breathing and was relieved on taking medication. The patient also developed cough for the past 6 months, which was productive in nature. And it also used to occur multiple times throughout the day. The sputum was mucopurulent mixed with mild amount of fresh blood each time. And it also relieved on taking medication. There is a history of acute chest pain right-sided, along with shortness of breath 4 months back, for which the patient was treated at the emergency department. Okay, so coming to the next slide, on general examination, overall, essentially everything was normal except for presence of mild to moderate anemia. On auscultation of the chest, there was a diminished vesicular breath sound on right side, and mild crepitation was also present on the right upper lobe area. There was no associated adventitious sound, and left side was within normal limit. CBS was within normal limit. There was nothing. Other system were also within normal limit. And coming to the next. A series of investigations were done, which I tried to list it in chronological order. Ultimately, the bronchoscopic biopsy, it was diagnosed as a non-small cell lung cancer, and recent FDG PET-CT also suggestive of the metabolically active primary lesion in right lung, upper lobe, perihilar lesion with distal collapse, and few small active ipsilateral mediastinal lymphadenopathy. There was no obvious other abnormalities. His blood reports was also essentially normal, except for hemoglobin was 8.5 gram%. He currently receiving neoadjuvant chemotherapy with injection paclitaxel and carboplatin. 3 cycle has been completed so far. Coming to psychosocial aspect, the patient belongs to lower socioeconomic status. He has a wife, son, and daughter-in-law, total 4 members in family. Currently, he is not working. He used to work as a daily wage laborer. Household income is not adequate, and son is the only breadwinner right now. Wife and daughter-in-law take care of the patient. They are living at their own house, and the patient has a history of smoking. His religion, by religion, is Islam. He knows about his diagnosis from the beginning and was fearful initially. but at currently he's only bothered about the physical symptom that he's experiencing, like the pain, weakness, and other chemotherapy-related side effects. He's currently on the following medication. Initially, he was started with tablet paracetamol 650 milligram, which was not efficient for managing his pain. So it was the dose was increased up to 1 gram TDS, and also receiving other medication like Rantac, Ondem, multivitamin, iron, folic acid. And in the past, during the acute attack, he used injection diclofenac along with injection tramadol and other supporting medication. He is receiving chemotherapy, and during the chemotherapy days, he is receiving tablet dexamethasone and phenylnamine maleate. Okay, next slide. There is some small details of which ma'am already beautifully discussed already. The diclofenac it acts by inhibiting the prostaglandin synthesis and somewhat COX-2 selective. It is metabolized and excreted both in urine and bile. Plasma THP around 2 hours, and maximum dose can be given 150 milligram per 24 hours. It is basically used in various conditions like rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, and very much effective in various acute pain conditions to give prompt relief. Adverse effects are like the other NSAIDs, but mild and associated with nausea, headache, dizziness, and sometimes rashes. Gastric ulceration and bleeding are less common as compared to the other NSAIDs. And paracetamol also, as ma'am already mentioned, it has very poor or no anti-inflammatory action due to the poor COX-1 inhibitory mechanism, and it basically acts by centrally inhibiting the COX-3, which is present in the cerebral cortex. It is also metabolized in the liver by glucuronidation and sulfate conjugation. Its plasma THP is around 2 to 3 hours, and maximum dose that can be given per 24 hours is 4 gram. It is a mild to moderate pain like headache, musculoskeletal pain, or dysmenorrhea, pain during the dysmenorrhea. Adverse effects are usually safe and well tolerated, and sometimes nausea and skin rashes are there, and some reversible and mild increase in the hepatic enzyme can occur. So coming to the main concern regarding this patient. Next slide, please. To adequately manage the pain on his right side of the chest, which get worse occasionally, and it interferes with his daily activities, and the chemotherapy-related side effects which interfere with daily activities. He also has some financial concern as well. To summarize, this is a 69-year-old male patient who is non-hypertensive, non-diabetic, and chronic smoker, but non-alcoholic, presented with right-sided chest pain for the last 1 year, and with cup with hemoptysis for the last 6 months. So regarding the case, the discussion points are the palliative care for this patient, the parameter we should look for chronic use of NSAIDs, and what other analgesic can be used in this case if possible, the problems facing by this patient, and what else can be done as palliative care physician in this case. Thank you. This is it. Over to you, madam.
Thank you, doctor. Basically, we can go one by one with the discussion points, what you would like to. What are the facilities available, and with the medications, how, like first, this regarding palliative care for the patient, what are the facilities available in your center that could be provided for him?
We can provide his pain medications along with the nursing care.
morphine, all pain medications are available in your center?
Yeah. Actually, patient is being treated at the tertiary care hospital and medical college and hospital. Our center morphine is also available.
Okay.
Currently, patient is receiving paracetamol only. His pain is under control, almost under control.
So, like, what was the pain score when he came, and what is the pain score now with the medications?
During the acute exacerbation, according to patient, it was very severe. Like the patient was confined to his bed and screaming all the time, score of 9 to 10 approximately. And at present, he received a pain at a score around 2 to 3, according to him.
So you have dealt with some other issues also for him. That is why, see, as we have been telling about total pain, you have looked into not only physical pain. So
yes, he actually also has some mental concern and spiritual aspect too.
See, with your information only, I am telling all this, isn't it? Because I have not seen your patient. But see, exactly this is what we say. Physical pain is also there, but again and again, follow the definition of pain. Physical, social, psychological, all elements contribute. Many times we say that you have to look into everything. What is that bothers them the most? That is what, if you ask, we may be thinking physical, but they may say, no, I have some issue. My son is, I am unable to help my son, or I'm unable to help my wife or daughter. I am very dependent. Something like that can come up. So that is why I asked. And
he also used to say, like, he is a spiritual, actually, Islam by religion. He also used to say, like, why this happened to me. Like, I used to work a lot. I'm a hardworking man, but I don't know why this happened to me. Something like that.
And madam, what is that you want to add on, madam? Maybe we can come out of the screen, Shri Priya, because that may be better for everyone to interact.
Yeah, so I think that we should have, the extent of pain, the degree of pain should have been like Radha just mentioned. We should know the pain score. It helps in monitoring the trend and the adequate management. And you have done a good job of treating the physical pain. But like this gentleman has also got psychological issues, he's got social issues, he's got spiritual issues as well. So the psychosocial worker can also help in this handling this. And of course, even as a doctor, giving reassurance to the patient, that right now he's bothered about, will I suffer with pain? So we have to tell them that, your pain we can take care of, you will be comfortable. And whatever issues he needs to settle with his family can be done. So there's a closure on all that front, because he may be knowing the prognosis, but we can make it easy, a little easy for him as he's going through this journey. So where the physical pain is concerned, I think you've done a good job, but the other issues also need to be addressed. Maybe we can add an antidepressant also. Along with the counseling part, you can add a small dose which will help him get sleep and allay his anxiety and depression to a certain extent. You can add a tricyclic antidepressant also. And if the pain is relieved with just this, otherwise we have not added a neuropathic pain. I don't think he has got much of neuropathic pain, but if he has, then that also can be added. But since it has been treated, I presume it is mainly nociceptive pain. He doesn't have tingling, numbness, or burning. Then the neuropathic element is not there. But an antidepressant, a sedative can be added on, which can help in the, addressing his a bit of his psychological issues, but nothing like verbal reassurance and verbal support also.
And even what madam is telling, just like 10 milligram amitriptyline, 10, 12 milligrams, with that itself, many patients settle very well. Yes, and as she's mentioned, you're seeing the patient regularly. See how, if he says next time, oh, my pain is okay, but my sleep is not okay. Something like that, if he says no, that's where those are the cues and clues we have to pick up.
And
Okay.
also look at the other symptoms. Is he constipated? What are his bowel habits? Does he have a sense? They all have, cancer patients all have, not able to eat much. Then you may have to add other drugs like maybe a perinorm, or maybe you have to add a laxative. So these things also can be added on if necessary. It's palliative care is not just pain, it is also symptom management. So you have to see everything. What is he eating? How is he eating? Is he taking, small frequent meals? That is what they have to take in cancer, because they're not able to, digest very well, and they have a little bit of an anorexia. So small frequent meals. And what type of meal is he taking? Is it a nutritious meal, or, that also you can advise him, and, everything. It's just a total pain management. Total pain management includes everything, not just the physical part of it.
And his query for monitoring when patients are on diclofenac, NSAIDs, that one, what would you like to add on, madam?
See, diclofenac and NSAIDs should not be given on a long-term basis. Okay? Because particularly his kidney function was all right, but even then you should use it initially, but then you have to ultimately confine yourself to paracetamol or drugs like tramadol. You can give it for 1 week, 2 weeks, 3 weeks, but you can't continue that for long. Of course, his life expectancy is reduced, then maybe you can give it. But just remember, he's 69 years old, and we don't know whether there are other risk factors for NSAIDs toxicity. I'd mentioned all the risk factors, but advanced stage, long-term use is generally discouraged for non-steroidal anti.
Short pulses is what you can use, and then you have to monitor. See, and then with kidney functioning, unfortunately, when the kidney is really very, very bad, only you will see parameters. Even 15, up to 15, 20% of the kidney being lost, only 15% functioning kidney left also, your numbers may not show very well.
The creatinine and urea and all will rise there.
Kidney function alone may not be. So that's why, as madam said, we always say, use short pulses to get the benefit at that point of time. Not like there are many who take like that. And I've seen patients in the last 4-5 years, 30-year-old being on dialysis. They say, oh, I was taking over-the-counter medication. They might have been on some form of diclofenac or whatever it is for months for some sort of pain. So those type of things do happen. So use it as and when required at that point of time.
A sudden exacerbation of pain you can give, for 1 or 2 days. Then again, come back to your paracetamol and maybe even tramadol. Tramadol is quite safe, in these patients.
Tramadol can be used chronically.
Pardon me?
Can't hear you.
Tramadol, for how long we can use tramadol?
It can be used indefinitely.
You can safe.
Okay. Thanks.
So that's what, see, the main thing, or use that, follow that ladder, it is universal. What has been told today, use 1 + 2 additive effect, opioid sparing effect, so many things are there. You can use paracetamol and tramadol, and you can use like amitriptyline or anti-neuropathic and painkiller. Like that, you try to use them so that you don't use excessive dose of any one thing. So that's why, and then pain as such, is, we say generally, one more simple term with the pathophysiology, pain is not a hardwired, our central nervous system is not a hardwired system, one way alone. It is neuroplasticity. That's why we have so many variety. It causes amplification, it causes sensitization, it causes wind up. So many things are there. That's why it is, I don't want to use the word tricky, but it is like that because of the nature how our CNS works. So understand that and use various types of medications, and use it for some time, taper them and switch off. Even antineuropathics we have used for some time, take them off, put them back on. All that is possible. So
there's one question here that for practical purposes, any opioid plus adjuvant combination that should be avoided. So opioid is, you're talking of a strong opioid like morphine, is it? Who's this person?
Sri. Is that right?
Yeah.
What is that you're asking, please? Is it, as madam is asking, is it like weak opioid or a strong opioid? What is your query?
Ma'am, any opioid, like in the ladder, we first see the weak opioids, then the stronger opioids. So, with the ma'am's experience, I just want to know her practical point of view. Is there any combination while prescribing that we should avoid at any cost? Considering the drugs given under opioids as well as in the adjuvants, is there any drug that we should be, are there any combination of drugs that we should be avoiding at any cost? Like, don't combine these two amongst the drugs that ma'am has stated.
I cannot offhand think of anything that can be avoided along with opioid. Okay.
There's no hard, like as madam is saying, but generally people have a fear. I'm just telling you because tramadol and amitriptyline, they say epileptic threshold. These are all, but in practice we have used, because both you're using at low level. The amitriptyline, if you properly use, because the analgesic dose what we are using, we start at 10 or 12.5 milligrams and go 25, 50. We are not using a psychiatric or psychotic dose.
Yes.
Okay, that is the important thing to remember. Because from the way the question came, this is what normally I've heard this in this. I've been practicing pain for nearly 12, 15 years. Okay, so this is one doubt which always comes up whenever tramadol and amitriptyline is given. But the dose is what is important there. I don't know if that was your query. I'm just
we are very often combining tramadol and we're giving amitriptyline also, tricyclic.
Exactly. As I said, I've used it, but the thing is that I will use only 10, 12.5 because amitriptyline normally 12.5, 25 with that, or max is 750. That
even
50
I don't exceed that.
Less.
Even I don't exceed that dose.
50 itself is very rare. With 25,
25 only I will settle down. I never even go up to 50.
So with that 25 and tramadol, so far, touch wood, in 15 years, it has been okay. So like that only. So there's no hard and fast. You should not give anything like that. That too didn't come up to my mind. That's why I just wanted to add on. Because from the question, that's the normal query which comes up. So I hope that has satisfied your query. Okay, there are no more questions in the chat box. I hand it over to you, Sri Priya.
Thank you, Mary ma'am. Thank you so much. It has always been a pleasure, for us listening to your knowledge data bank, if I could say. So thank you so much for sparing your valuable time for our cohort of doctors. And we do definitely look forward to having more sessions with you in future as well. Thank you everyone for joining us on this wonderful evening and making the session interactive. We wish everyone a very peaceful weekend and a happening week ahead. This is Sri Priya, along with Dr. Mary Abraham and Dr. Rata Venkatesh, signing off from the Tipsy Hub. See you in the next session. Till then, everyone, take care. Bye-bye.